Hi, my name is Dr. Marysia Tweet. I'm an associate professor in the Department of Cardiovascular Medicine at Mayo Clinic in Rochester. And it is my pleasure to host the podcast series entitled The Intersection of Cardiovascular Disease and Female Reproductive Health. I'm excited today to introduce our speakers for our cardiobstetrics topic number 1 of 3, entitled Does Lifestyle Affect Pregnancy and Congenital Birth Defects? And our expert guests are Dr. Katie Young and Dr. Carl Rose. Dr. Katie Young is a board certified cardiologist and assistant professor of medicine at the Mayo Clinic College of Medicine. She obtained specialty training in internal medicine, cardiology, and advanced cardiac imaging at Mayo Clinic in Rochester, Minnesota. She is currently the cardiology director of the cardiovascular obstetrics clinic at Mayo Clinic in Rochester and actively practices in both the echocardiography and nuclear cardiology labs. Her clinical interests include treatment of cardiovascular disorders related to pregnancy and community cardiology. Dr. Carl Rose is a professor of maternal fetal medicine. His residency training was at Baylor College of Medicine in Houston, and his fellowship was at the University of Mississippi Medical Center in Jackson. Then he came to Mayo Clinic here in Rochester in 2005. He's also served as the Maternal Fetal Medicine Fellowship Director in 2017. Dr. Rose has been my go-to for all of my maternal fetal medicine related questions for my cardiovascular patients, as well as Dr. Young as the current director of our cardiobstetrics team. So thank you both for agreeing to join me today to answer some salient questions that commonly come up in my clinical practice, but I believe in a lot of other people's clinical practices, and often are questions of very much interest to our patients.
Thank you,
Happy
Marysia.
to be here. Yep.
So I'm going to start with a question, and this is a broad question, but if any woman becomes or wishes to become pregnant, what can she do to minimize the risk during pregnancy or the postpartum period of adverse events?
There's probably several things that I would suggest in this situation, and probably the most important aspect is to start with prenatal vitamins with supplemental folic acid, which will potentially reduce the risk of fetal spina bifida and other open neural tube defects during the pregnancy. In addition to that, we would suggest optimizing any particular ongoing medical concerns. And if medication therapy has been required, that we transition that medication therapy to something that would be considered safe to continue during pregnancy. Certain medications need to be discontinued, or certain other medications we would transition to different medications or categories of medications as appropriate. We would think about, if possible, reducing household or employment related teratogenic exposures, if any exist. We generally suggest trying to avoid eating uncooked foods, uncooked lunch meats in particular, and avoiding potentially any type of fish that have a very high mercury component to them. We also, along those same lines, we talk about avoiding potential teratogens such as alcohol, tobacco, or any other type of illicit substances. And beyond that, really ensuring that one's immunizations are up to date and as appropriate for any particular individual, screening for sexually transmitted infections as well.
Awesome. Thank you. Are there certain lifestyle choices that are known to cause pregnancy complications?
Yeah, good question. There's an association, we think, between core temperature elevations in the first trimesters of pregnancy, particularly prior to 6 weeks gestation, and spina bifida, open neural tube defects. So in general, we avoid suggesting any exposure to hot tubs or anything else that would potentially increase core temperatures. We suggest against avoidance of any alcohol. There's no amount of alcohol that's known to be safe, if you will, during pregnancy, and tobacco cessation and any illicit substance use as well. Also, if we have moms who have preconceptual diabetes, optimizing one's glycemic control would be advantageous as well.
What about obesity and fetal anomalies? And maybe Dr. Young, maybe I'll get your impression first, and then Dr. Rose, you can weigh in as well. What are your thoughts on that?
Thanks, Marsha. Yeah, so I think, and I'll make a couple comments too, because looking at preconception counseling from a cardiology lens, I think that I really rely on my collaboration with Dr. Rose and obstetric and MFM colleagues to really help us with that comprehensive counseling. And then I think when I have a patient who expresses interest to become pregnant, and they have some underlying cardiac disease, so whether it's a valve condition or heart failure, cardiomyopathy, I think my goal really shifts to how are we making sure they're as optimized as possible, and do we need to do anything else to really optimize them to have the safest pregnancy possible? That implies, looking at their cardiac conditions, but also their other comorbidities. And I do think that obesity is one that I try especially if the patient knows that they are looking at pregnancy in a year or 2 years, and we're just starting really initial discussions. I feel strongly, and I do bring it up with my own patients, that if they do have significant BMI elevation, that we really try and be focused on trying to improve their lifestyle, whether it's exercise, diet, and really work on that weight reduction, knowing that with pregnancy there's additional weight gain, and really to help them just ensure they have the healthiest pregnancy possible. So I do talk about obesity and weight loss, particularly if we have the advantage of knowing that we have time before they become pregnant. And that's not always the case. In fact, that's probably the minority of patients. Honestly, I think most patients kind of come to us either pregnant or they're pregnant the next month. But in those cases where, we have the opportunity to work on things like that over a period of time, I do encourage that. And if patients qualify and they're able to use even tools like the newer agents we have in our toolbox, like GLP-1s, I do work with patients to use those just to help modify and optimize all of their comorbidities prior to a pregnancy.
Excellent. Now, you brought up GLP-1 agonists, which, as you all know, they're the trendy medication that's been around now and getting a lot of popularity, and a lot of patients have been going on them. Dr. Rose, what do you think about GLP-1 agonists? And I imagine there's not much data out there for this group of patients, but I'd be interested in your thoughts.
Yeah, I think that's correct, Marisha. The short answer is we just don't know. They're too new to really have derived much reproductive data on. In general, we are suggesting cessation at time of conception. If someone is interested in conceiving, I think that's a little more of a gray area because the time to conception can be variable. And as a consequence, I don't know that we would suggest discontinuing them when one is trying to conceive. But the data right now is very limited, and there's really not good human data to base any strong recommendations on.
Another medication classification, at least, that's been getting increasing attention are the statins. So, I mean, Katie, I think you would agree during training, and you too, Carl, statins are teratogenic. We stop them. Even if someone's trying to get pregnant, we usually take them off of them. But there's certain circumstances I think we're realizing that they may be useful. I'm still very gun shy. And any of my patients who are thinking about becoming pregnant, I've stopped their statins. But what's the emerging data? Or can you give us a clue as to where this is headed? Because I've heard some information about pravastatin and some trials related to that. So I'm curious for your thoughts, either of you or both of you.
Yeah, I can take that one, Katie.
Yeah. Yeah.
There is a small amount of data at this point in time on use of pravastatin starting in the early second trimester for prevention of preeclampsia. And there is some data out there additionally on the treatment of preeclampsia once the disease has been established. Right now, probably the majority of data is on the prevention of preeclampsia in patients who are very high risk. And typically it's been started somewhere between 12 and 20 weeks gestation. And the initial data is promising. It does appear to reduce the recurrence risk for preeclampsia versus a placebo approach. But I think right now we simply do not know whether that's appropriate or not. From a teratogenic or concern for birth defects, generally we're not going to see that type of thing when starting after a 12 weeks gestation. And clinically speaking, there doesn't appear to be a higher risk of growth issues in exposed babies at this point in time. We don't know long term about any neurodevelopmental outcomes at this point.
Yeah, and I would say, and I agree with you, Marysia, in my clinical practice, and I think kind of broadly in our cardio OB practice here, we also are still holding statins when they become pregnant for breastfeeding, of course, as well. So we have not started implementing, that use for either preeclampsia prophylaxis or continuation of statins in pregnancy at this time. But again, I think you're right. I think it's emerging, and I think in 5 to 10 years we will likely be doing something different.
Awesome. Thanks for the input. Now, also on the topic of medications, what about aspirin? So, are there women you would treat with aspirin? What dose would you use? What are your thoughts on that?
So aspirin use has been shown to reduce the incidence of preeclampsia in patients with previous early onset preeclampsia. A lot of the initial data has come from the European trials, which used a 150 milligram dose of aspirin. And unfortunately, that's not available in this country. The current recommendations are to use 81 milligrams of aspirin starting between typically 12 and 14 weeks gestation for patients who are considered to be at high risk for developing preeclampsia. And those are, again, someone who's developed preeclampsia in a previous pregnancy, multiple gestation, underlying renal disease, underlying autoimmune conditions. And then there are some minor risk factors that we look at in addition, which take into account family history, ethnicity, BMI, which also influence decisions to start low-dose aspirin. There is some data out there that higher dosages, 162 milligrams or 2 baby aspirin, may be more efficacious, but I think that data is very limited right now. And typically this is started once someone has actually conceived and once again is in the late first, early second trimester.
Yeah, and I would say probably almost all of our cardiac patients fall into that bucket, and we use aspirin. And I think most of our patients are on baby aspirin. And some, depending on what their cardiac condition is, or if they have valve disease or, coronary disease history, they may even be on aspirin, in that first trimester as well. So yeah, we, agree with Carl very much. Yep.
How about if the only risk factor is advanced maternal age? Is that a reason to give daily baby aspirin, for example? And what's that age that you cut off that you use?
We use advanced maternal age is technically 35 years of age or older at time of delivery. As an isolated risk factor, it's considered a minor risk factor, Marysia. And if one has any other additional risk factors, such as BMI or it being first pregnancy or ethnicity, multiple gestation, or again, some of the other concurrent medical conditions, then yes, we would.
So another question I have is about blood pressure management. Obviously, a lot of us care for patients with high blood pressure or manage their blood pressure when they're not pregnant. But how does that change when you have a patient who becomes pregnant? And what are their goals?
Really, a couple things in terms of medications to use, which I think is important to know. So, some of our main blood pressure medications, of course, are like our ACE inhibitors, our angiotensin receptor blockers. And those, of course, we cannot use in pregnancy. So those have to be transitioned to alternative therapies if this is someone kind of with pre-existing hypertension going into pregnancy. Those are the big ones. And I would say if someone is diagnosed with hypertension during pregnancy, most commonly what we'll see used is labetalol and or nifedipine. So those are kind of the agents that are first line used. of course, considering their underlying, if they have any other cardiac conditions and such, but just hypertension in pregnancy, labetalol and nifedipine are certainly safe. And those are going to be what our OB colleagues, I think, are most comfortable with using as well. You can use, like your thiazide diuretics, hydrochlorothiazide. We know those are really helpful in controlling blood pressure, and those are safe to use in pregnancy. Usually, you're adding it on with another agent, but that would be another agent to consider as well. But those are kind of the main ones that I would say we see most frequently for someone that's being kind of pure hypertension that's being managed in pregnancy that we use. And then, Carl, I don't know if you want to speak to cutoffs for what we use.
Yeah, so in obstetrics, we have historically and currently use a threshold of 140/90 systolic over diastolic millimeters of mercury to make the diagnosis of hypertension. And I recognize that that doesn't necessarily fit all of the criteria prior to pregnancy. So we have adopted sort of a pragmatic approach. If someone presents to pregnancy and they have been diagnosed with underlying pre-existing chronic hypertension, in those situations, we manage the pregnancy as such, irrespective of what the blood pressure criteria initially used to make the diagnosis was. However, if someone does not have an antecedent diagnosis during pregnancy, we are using those threshold numbers to, of 140/90, to make a determination whether someone has baseline hypertension.
That's very helpful. And then is that the number used to decide to start treatment then, essentially?
Great question. So
Sorry, it's a tough question.
Yeah, so historically we used to actually treat at 160/110. However, 2022, the CHAP trial suggested that in patients with baseline hypertension, treatment to achieve blood pressures less than 140/90 seemed to be associated with lower incidence of superimposed preeclampsia requiring preterm delivery prior to 35 weeks. So that has become a standard of our standard tenet, if you will, of our management strategy in moms with chronic hypertension.
I appreciate that. The last question I'll have for you, and then I'll ask for closing remarks. We talk a lot about monitoring the mother during pregnancy, and we may get into that further in our topic too. But are there any factors, lifestyle factors or otherwise, that would prompt you to do more focused surveillance, fetal monitoring specifically? So any thoughts on that?
So we do antepartum fetal monitoring based upon maternal BMI. And we will start that contingent upon, at the gestational age, depending upon what maternal BMI is. It is uncertain whether antepartum fetal monitoring is beneficial in patients with ongoing substance use disorders during pregnancy. Commonly, we do. And those are probably the biggest lifestyle aspects that I can think of, Marysia.
Okay.
And many of the other indications for antepartum monitoring tend to revolve around coexistent medical conditions.
Okay. When we say antepartum monitoring too, I should probably clarify, what do you mean by that?
What are called non-stress tests or biophysical profiles. When we bring a mom in once or twice a week to monitor fetal status at that point in time, either by graphing out fetal heart rate patterns or watching on ultrasound to demonstrate different fetal movements that reassure us that at that point in time, a baby is doing well.
Okay, so this is like on top of the usual monitoring, essentially. Awesome. I really appreciate it. I'd like to wrap up in the interest of time, but before we say goodbye, any final words that either of you would like to impart? How about Dr. Young, you first, and then Dr. Rose?
Yeah, so this is again kind of speaking from cardiology lens, but I really hope that these podcasts really encourage a lot of our cardiology colleagues, that are helping care for a lot of young women to really make discussing their reproductive goals and pregnancy planning, as part of their routine cardiology care, so that we can start these kind of conversations very early for our patients and really get them optimized and really in the best shape possible to then have, help work towards their goal and have, help build their families. So I thank you, Marysia, for inviting us here. And just glad to be here and be a part of it.
And Carl, any parting words? Yeah.
I would second everything that Katie says. And as an obstetrician, we always appreciate the opportunity to talk about these things prior to conception, as opposed to once someone is actually conceived and we are working at that point. So, yes.
Awesome. Well, thank you both. And I appreciate you joining me today and having these conversations.
Thank you.
Thank you.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Mark Moline, Wound Clinic Director of the Cardiovascular Center at Mayo Clinic in Rochester, Minnesota. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Head to cveducationmayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses, all created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.